So this was the spotlight poster presentation, Innovations in Pathology, which included 4 pathology posters. So I'll just, yeah. First. Now, we all know the digital pathology is a environment or digital imaging, and it starts with whole slide imaging. With the advent of rapid scanners and the decrease in storage cost, it has been adopted across the world. Now, primary digital diagnosis, it started in earnest in 2017 when the FDA approval was granted to Philips ultra-fast IntelliSight scanner, and this led to increased clinical adoption in US, and it was further accelerated by the pandemic because it permits remote viewing and diagnosis of the digital images. Now we come to a very important topic, computational pathology. Now, computational pathology is defined by Digital Pathology Association as omics or big data approach to pathology. Now, in this, multiple sources of patient information are including the pathology image data, and metadata are combined to extract the patterns and analyze them. Now, the Page Prostate was the first FDA-approved AI product for digital pathology. This Page Prostate is a New York-based AI company startup, and it was started by Dr. Thomas Fuchs, and in 2017, and you'll be surprised to know it received $220 million of funding, and this was the first system, which was a landmark, which received FDA approval. So, what are the opportunities of this computational pathology? Now, first is it improves diagnostic accuracy, the efficiency of the pathologist. We can say that for Page Prostate, where they showed that the diagnostic accuracy for the slides, which was screened by the pathologist in first read, the second read, and then the assisted read with the AI product, led to improvement of 7.3%. And it also leads to increased efficiency because it highlights the suspected areas. For example, if it is a very small area, it will be picked up by the AI system. So this is the advantage of computational pathology. Now coming to the resource limited settings. Now in resource limited settings, like where you don't have the subspecialty practice or the specialist pathologist, you can use the AI system to assist the pathologist in making a correct diagnosis. And it helps in develop better diagnostic and prognostic criteria with objective and quantitative measures. So that is, we can say for, say, prostate biopsies, where the accurate Gleason scoring, the quantification can be done. Now, what are the challenges? The biggest challenge, as we will see in subsequent posters, that the volume of data, the slides which are required, is enormous. And second issue is the quality of the data. The data has to be curated, it has to be properly annotated, and it has to be accurate. If you have a faulty data, it will give rise to a poorly trained AI. Now coming to computational and digital infrastructure challenges. Now computational challenges are that you require a very good hardware to run this softwares and generate proper results. Now digital infrastructure, as you know, the bandwidth and other problems come. Now, the first poster is Subtyping Invasive Carcinomas and High-Risk Lesion for Machine Learning-Based Breast Pathology. Now, this was presented by Matthew G. Hanna in collaboration with Page AI, and the first two posters are both from Memorial Sloan Kettering and Page. Now, what they have shown is this, that they used Page Breast Beta. This is a software, AI software, and they use it to classify pre-neoplastic and neoplastic diagnostic category, just like we have seen with the Gaurav's poster using IBEX AI system. Now, they also classify the histological subtypes like apocrine, mucinous, and others. So you can see the amount of data they have used. For training, they use 40,000 slides, and for validation, 11,400 slides. So this is a massive amount of data which they could source from Memorial Sloan Kettering. And they trained using slide level labels. Now, what are slide level labels? Now, this slide level labels are the ground truth which is given to one particular whole slide image. So you say that this slide is, say, invasive breast carcinoma, and whichever type it is. So that becomes the slide level label. Second approach is to give patch level labels that we'll see in last poster. So subtyping of invasive breast carcinoma, they have shown that, like for solid papillary, it was area under curve was 0.90, and for mucinous it was 0.99. So it was excellent, and for pre-neoplastic also it was quite good. And you can see the page, it marks the area of interest, in this case malignant duct, by heat map. So to conclude, they said that trained CNN has high performance in identifying the presence of ADH, ALH, DCIS, IDC, ILC, LCIS, and the subtyping apocrine, micropapillary, mucinous, solid papillary, and tubular carcinoma. So they have expressed this hope that this can be used to detect microinvasions and calcification in breast tissue using the same approach. Now, the second abstract, the poster is also from the Memorial Sloan Kettering. This was presented by George S. Rees-Pillow, and this is based on an artificial intelligence-based predictor of CDH1 biallelic mutation and invasive lobular carcinoma. So, aim of this study was to basically identify the invasive lobular carcinoma and biallelic CDH1 inactivation. Why invasive lobular carcinoma? Because the diagnosis of invasive breast lobular carcinoma is sometimes difficult, and it has a lot of inter-observer variability. And they said that molecular surrogate, that is biallelic CDH1 inactivation, is highly specific for invasive lobular carcinoma. That is, more than 95% will have some changes in CDH1. So what they did was, they curated 1,100 primary breast cancers which had been subjected to genomic analysis at Memorial Sloan Kettering, and they gave it a ground truth that they should have somatic mutations or mutations plus LOH. Now, these were used for training. So this was their data. CDH1 was there in 143, it was biallelic, and 957 were wild type. Lobular subtypes histologically were 173 and 927 were non-lobular. So they evaluated the revised ground truth, and that further reclassified some labels. So this is invasive primary cancer sample, In that, they apply the previous software, what we have seen, breast beta, that was trained on 40,000 whole slide images. Then it was used to identify the salient tissue, and on this they applied the CDH1 by allelic mutation classifier system. Now this further gave the two classifiers, CDH1 by allelic mutation and no CDH1 mutation. So what they said was that if you use this the training set as a curated data using the ground truth of CDH1 mutation, you get better sensitivity and accuracy than using the histological label that is which is used for lobular carcinoma classification. So that they concluded, by training a machine learning to detect CDH1 by allelic mutation as ground truth rather than histologic diagnosis of lobular carcinoma, which might be confounded by human subjectivity, they developed an AI-based system that can detect ILCs accurately, provide new paradigm for use of orthogonal ground truth. So that was their conclusion. However, we should understand this, all this is research setting, and these are not in diagnostic use. Now coming to the last poster. Now this was on deep learning applied on resection specimen. The tissues slides of pure ductal carcinoma in situ predicts ipsilateral invasive breast cancer recurrence. Now this was presented by Dr. Shannon Doyle. She was from Cancer Institute, Netherlands. Now their premise was that ductal carcinoma diagnosis is overtreated, that is by surgery or by radiation. So they try to predict the recurrence of invasive breast carcinoma in the ipsilateral breast by using the training set of 235 HNE slides, which had 10 years follow-up with no radiotherapy and had recurrence in 167 cases. So this was their training set which they used, and the detection used was, as we have already said, a patch approach was used, in which the part of slide was annotated and then it was aggregated. So detection of ducts followed by duct level classification and aggregation was used. So this is their data. The RT negative, 249 cases, 125 recurred, 125 no recurrence. And in cases where RT was given, out of 143, only 42 recurred. And WSI was tiled two patches of 1024 into 1024 pixel. So this was use of patches, and slide level approach we have seen with previous two posters. So deep learning was applied, and 10-year IBC recurrence risk was calculated with 5-fold cross-validation. What is 5-fold cross-validation? Say if you have 100 cases for training, what you do is you divide them into 5 equal parts, say 20-20, and then use 40 for training and 20 for validation. And you repeat it 5 times so that your algorithm get good training. So this is one way. However, their numbers is very small compared to the MSK CC cohort. So self-supervised pre-training improved performance for RT negative subjects. So what is the self-supervised pre-training? So in self-supervised training, what is done is the deep learning algorithm is allowed to learn by itself. However, it withheld some part of information by itself, and then the system is encouraged to predict the hidden part. So that is called self-supervised learning. So they concluded that distinguishing lower and higher subsequent ipsilateral IBC risks was possible by their model, and they have shown that this area under curve was 0.93 when only RT negative subjects were used for training. So it improved from 0.81 to 0.93 when only RT negative subjects were used for training. So correctly distinguishing lower and higher subsequent ipsilateral IBC risk, personalized DCI management for patient, where active surveillance rather than surgical removal of lesion may be possible, potentially identifying biologically relevant features of DCIS progression, and they excluded radiotherapy treated cases as they are likely to reduce prognostic power of model as radiotherapy treatment reduces ipsilateral IBC recurrence. Now to summarize, the use of deep learning algorithms improves lesion detections. DL models can help in risk stratification. The training validation data remains a big challenge because we have already said you require a huge amount of number of slides to actually train an algorithm so it can be accurate. With small amount of slides, the training is incomplete. It will give you errors. And sharing of resources by federated or swarm learning is the way forward. What is federated and swarm learning? In federated learning, what you do is, like I put my all slides into the cloud, and say Apollo puts all in the cloud, and Tata puts in the cloud, and anybody who wants to validate their AI system can use that cloud to validate the AI platform. So that is the idea of federated. Whereas in swarm learning, there are multiple nodes. So you can, using the data at different nodes, you can train your system. So you have to give your codes to all other centers. They will validate independently your AI system. So these are two ways of learning which may be the way forward. Now just about something about future. This Muse Microscopy is basically microscopy with ultraviolet surface excitation. It is a novel microscopy technique which can actually scan the tissues on the blocks also. So there is no need for scanners, no need for bright field microscope. It generates a 3D image, and it can actually develop a more accurate precision medicine models because it has much more information, the spatial information with epithelial cells, the stroma, and the inflammatory cells. So it may be the future and may replace the conventional models what we are using now. And it is faster, cheaper, and it can give you better prognostic information. Thank you.